Chapter 20, Part 1, Somatic Symptom and Dissociative Disorders. Somatic symptoms and related disorders are classified as mental disorders because the person is complaining of physical symptoms. However, the medical examination is normal and has no finding of any illness. So there is no medical explanation for these physical symptoms they're complaining about. However, these physical symptoms are causing significant distress and an impairment in one's functioning. This is the definition for somatic symptoms and the related disorders. So some of the related disorders to somatic symptoms include anxiety disorder, conversion disorder, factious disorder, psychological factors that affect the medical condition as well. So some dissociative disorders include depersonalization, derealization disorder, dissociative amnesia, dissociative identity disorder, and there are others. So dissociative disorder is defined as a disruption in the normal integrative functions of the conscious, memory, and identity. Dissociative responses occur when anxiety becomes overwhelming. Somatic symptom disorders have been identified as hysterical neurosis or hysteria and were thought to occur in response to repressed anxiety. Some 4,000 years ago, it was associated with witchcraft, demonology, as well as sorcery. So, dysfunction of the nervous system and unexpressed emotions. Freud observed clients under hypnosis and discovered that they were able to recall past memories and emotional experiences that brought them symptom relief. This led to his proposal that unexpressed emotions can be converted into physical symptoms, resulting in the somatic symptom disorder, right? That's exactly what it is. Freud viewed dissociation as a type of repression, an active defense mechanism used to remove threatening or unacceptable mental content from conscious awareness. Epidemiology statistics. Somatic symptom disorders affect women and men equally. Conversion disorders are more commonly found in women than in men, less educated people, and in rural areas. So, illness anxiety disorder is replacing hypochondria or hypochondrias in our DSM 5th edition. So, this disorder is when a person has unrealistic fear that they have a serious medical condition or fear that they have a high risk of developing illness. This may misinterpret typical body function and the signs of illness, and it is believed between 3 to 8% of the population identifies with this illness, anxiety disorder, aka or also known as hypochondrias or hypochondria. Dissociative disorders, also known as DIDS, DIDS, or DID, are statistically quite rare. DID is more prevalent in women than men. Brief episodes of depersonalization symptoms appear to be common in young adults, particularly in times of severe stress. Okay, types of somatic symptom disorders. Somatic symptom disorders is a syndrome of multi-physical symptoms that cannot be explained medically and are associated with mental health. Symptoms may be vague, dramatized, or exaggerated in their presence, and an excessive amount of time and energy is devoted to worry and concern about the symptoms. Individuals with somatic symptom disorder are totally convinced that their symptoms are related to organic pathology and will reject any implication that stress or psychosocial factors play any role in these symptoms. The disorder is chronic. The symptoms begin before age 30. Anxiety and depression are frequent comorbidities to this somatic symptom disorders. Somatic symptom disorder usually runs a course with periods of remission and exacerbation. Clients often receive medical care from several physicians, sometimes concurrently, leading to possibly dangerous combinations of treatment. They have a tendency to seek relief through over-medicating with prescribed analgesics and anti-anxiety agents. Drug abuse and dependency are common complications of somatic symptom disorder. And I have a note here to refer to box 20-1 in your text, where it talks about our somatic symptom disorder and your DSM-5 manual, diagnosis criteria. So continue with the types of somatic symptom disorders. We're going to talk more in depth about illness anxiety disorder. So it is an unrealistic or inaccurate interpretation of physical symptoms or sensations leading to preoccupation and fear of having a serious disease. So these people fearful that they have a serious disease with no evidence basis to support that. The fear becomes disabling and persistent despite reassurance that there is no organic pathology that can be detected. So they may say they have cancer or think they have cancer. However, all tests are showing no cancer. Illness anxiety disorder continued. So individuals with illness anxiety disorder are extremely conscious of bodily sensations and changes, and they may become convinced that a rapid heartbeat indicates heart disease or a sore in their skin indicates skin cancer. They are profoundly preoccupied with their bodies and are totally aware of even the slightest change in feeling or sensation. Individuals with illness anxiety disorder are so apprehensive and fearful that they become alarmed with the slightest hint of illness or serious illness. Even reading about disease or hearing that someone they know have been diagnosed with an illness precipitates alarm on their part. Again, refer to box 20-2. Conversion disorder is a loss or change in bodily function that cannot be explained by a known medical or pathological mechanism. Conversion symptoms affect voluntary motor as well as sensory functions and suggest neurological disease. The most obvious and classic conversion symptoms are those that suggest this neurological disease. Some examples of conversion disorder include paralysis, seizures, difficulty swallowing, urinary retention, blindness, deafness, double vision, aphonia. These are some examples of symptoms that this conversion disorder will encompass. Psychological factors affecting medical conditions. So, because the person is a whole being, we cannot just treat the physical element. Their medical condition may affect their psychological status or their mental status. So, with this diagnosis, there is evidence of general medical condition that has been precipitated by or is perpetuated by a psychological or behavioral circumstance. However, in this disorder, it is evident that the psychological or behavioral factors are clearly implicated in the development, exacerbation, or delayed recovery from the medical condition. Refer to box 20-4 in your text for your DSM-5 diagnosis criteria. So factious disorder. So factious disorders involve conscious, intentional feigning of physical or psychological symptoms. So this feigning of physical and psychological symptoms just mean an exaggeration, extreme exaggeration. Individuals with factious disorder pretend to be ill in order to receive emotional care and support commonly. To accomplish this, they may exaggerate existing symptoms, induce new ones, or even inflict pain, injury on themselves. So individuals could pretend to be ill to receive emotional care and support commonly associated with the role of the patient. Factious disorder is also known as Munchausen syndrome, and this disorder may be imposed on another person under the care of the perpetrator. So it's very difficult to diagnose this disease because the individual or perpetrator is very inventive with producing symptoms to gain this attention because they feel that there is some type of disorder happening. Okay, we have ourselves a question. So a client is experiencing lower extremity paralysis and is admitted to the medical unit. Extensive tests confirm disability but rule out any underlying organic pathology. The nurse concludes that this is most suggestive of which disorder? A. Conversion disorder. B. Illness anxiety disorder. C. Malingering. Or D. Somatic symptom disorder. I'll give you a few seconds. And you are correct. The answer is A. Conversion disorder, which is a loss or change in body function resulting from psychological conflict and physical symptoms of which cannot be explained by a known medical disorder. The situation presented in the question describes a conversion disorder. Predisposing factors associated with somatic symptom disorders. So genetic, hereditary factors are possibly associated with somatic symptom disorder, conversion disorder, and illness disorder. Biochemical, decreased levels of serotonin and endorphins play a role in the etiology of somatic symptom disorder, predominantly pain. So continuing with our predisposing factors for somatic symptom disorders, brain dysfunction or impairment in information processing has been implicated as a factor in factious disorder. Psychodynamic theorists view illness anxiety disorder as a defense mechanism, and the physical complaints are an expression of their low self-esteem, feelings of worthlessness, because it's easier to feel something's wrong with their body than to feel that something's wrong with them. So conversion disorder may represent emotions associated with a traumatic event, and they find that these emotions are too unacceptable to express verbally, So they convert it to something that is acceptable, such as physical symptoms. Predisposing factors associated with somatic symptom disorders. So, family dynamics. In dysfunctional families or where family members have problems with expressing themselves openly and resolving conflict verbally, the child becomes ill. Focus shifts from open conflict to the child's illness and leaves unresolved underlying issues that the family is unable to confront openly. So, somatization brings some stability to the family and positive reinforcement to the child. So, this is a tertiary gain. So, the somatization in the child brings the family together, and it's a harmonious place where it replaces the discord because everyone's focused on the child's well being. Predisposition factors associated with somatic disorders continued, and we have our learning theory. Somatic complaints are often reinforced when the sick person learns that he or she may avoid stressful obligations or be excused from unwanted duties. This is considered a primary gain. This sounds like it could be test questions, right? Because we have primary gain, secondary, tertiary gain. So it may be predominant focus on attention because of the illness, which is a secondary gain. And the person may also learn that relieve conflict within the family because concerns shift to the ill person and away from the real issue, which is a tertiary gain. So with the learning theory, the individual learns that being sick can relieve them from obligations, primary, secondary, allow them to receive attention, and the third gain is that it will reduce the conflict that they're trying to avoid. Learning theory continued. So, with illness, anxiety disorder, past experiences with serious or life threatening physical illness, either personal or that of a close relative, can predispose the person to illness anxiety disorder. So, just as a recap, the fear of recurring illness generates an exaggerated response to minor physical changes, leading to excessive anxiety and health concerns. So, if you recall, I mentioned that they may have a sore on their skin, and now they think they have skin cancer. We have ourselves a question. So a client is experiencing pain that has no organic etiology. This pain allows the client to avoid going to work at a job that he hates. What describes what this client is experiencing? A. Altered social interaction. B. Disturbed thought processes. C. Primary gain. D. Secondary gain. I'll give you a few seconds. And the answer is C. You're correct. Primary gain, because the benefit to the client of avoidance of some unpleasant activity due to experiencing psychologically based pain. This avoidance directly decreases the client's anxiety. The situation presented in the question describes primary gain.